here, which is your AC joint, if you've heard of that. That's the junction between your collarbone and a bone that comes from your shoulder blade. And then I would have an anterior spot there. You sure you don't mind?
No.
Okay, good. All right, so, yeah, so if you had kind of a thought to sort of almost a triangle marker there, because from the side what we're looking at is alignment, so we can get a really good idea. Some people's shoulder really drifts forward, and that's important to us, so we want to see where that sits relative to the ear and then the rest of the body.
So Judy, would you need to
Yeah.
know relative movement between those three markers on the
No.
triangle, or just you could have one marker that sits there?
You bet.
Okay.
Yeah,
got it.
yeah. It's really just so we have that line up with really the rest of the
Yeah.
trunk. Okay, so here again, it's primarily posture. There's subtleties that we would look at in terms of how much this is sitting again forward versus here. Yeah, and then we'd have a look from the back. And so you go ahead and turn again, Rich. So this is actually where we spend most of our time, believe it or not, with the shoulder, because you're gonna have an anatomy lesson here, but the shoulder blade, that's the socket. So when we think about the shoulder as a ball and socket, this is what comes up and becomes the socket. So a lot of problems that we see in the shoulder really start here. And further to that, when we talk about managing the shoulder and good shoulder rehab, it's all this area. Okay, so that's really changed over 25 years before you were born, Christina. Okay, and so this is what I was thinking about last time, that if we're gonna have that really good analysis of the shoulder blade, because I'm gonna watch it as we do movement, I want that bottom corner, so there's an angle, it's kind of like a triangle. I want that bottom corner. I want this line, you can see there's a bump on the shoulder blade here, it's called a spine, so I want that. And then I want the top corner. So we're kind of looking at all of those three markers, okay? Okay, and so some of the subtleties that we look at here, I'm not sure how we're gonna address, because something like muscle wasting might be a little tricky. You see what I mean with that? Because muscle wasting is very subtle. If I'm looking to see if, this muscle here compared to this is a little bit less, it's a little tricky, but I think once you get into the software, we might be able to see.
Do you do that by feel or by look or both?
Mostly
Yeah.
vision.
Mostly vision?
Yeah,
Okay.
yeah. So that's one question mark maybe to think a little bit about. But if we're looking again at posture, we're looking at, the spine, we're looking at, again, those levels with the shoulder, which one's higher, which one's lower. And then with the shoulder blade, and I'm not sure if this is intuitive to you, but we'd have to mark both, right? So you'd have to have both blades marked. And you can actually see on Richard that he's normal, and his right shoulder blade is higher. So you can see that it's really important that we have that comparison between the two, okay? Okay, so observation-wise, that's good. So we look from the front, we look from the side, and then we look from the back, okay? And so, yeah.
And you would only mark the side which has got the
Yeah.
pathology, right?
Yeah, except the shoulder blade. Except the
right,
shoulder
right,
blade,
right.
I'd do that
Yeah.
on both, you bet. Okay, and so then I'm gonna go right into some movement stuff, okay? So I mentioned on that sheet, Christina, that in some situations we do quick look at the spine. So I just wanted to show you what that would look like. So Richard, let's start with your neck. Just tuck your chin down towards your chest. So now we're getting into movement patterns. Okay, and then come on back up, look up at the ceiling. Good, back to the middle. Lean your right ear to your right shoulder. And back to the middle, and then to the left. Okay, back to the middle.
So you're watching what's happening to the shoulder blade, not what's happening to the marker, right? Because the marker's
Right.
staying pretty well stationary, but the shoulder blade is definitely. So
Correct.
is that important to you at this point?
No, the markers are not important for this. In fact, probably you're giving me more credit than you should have, because really what I'm looking at is, does his neck move? Because you know how if you have a bad shoulder, there's a lot of people that have a real postural problem with their neck as well. And so we talk about a term called the kinetic chain, where we really are looking at the pieces that are all around that. And so again, for treatment, why that's important is if somebody has, very poor movement in this region of their neck, or they've got problems, then that's going to have an effect here. So it's kind of just a screening check, okay? So to be honest, I'm looking at comparing side to side movements, and just that, you know, a physio or a physician would be looking at general mobility within normal limits, okay? Yeah, so we're all, you know, really our assessment is always as a means to determine what's going on. It's always with that outcome of being able to figure out either a diagnosis, or in our case, it's most often to kind of make that deficiency list, okay, so we know how to treat. So that would be my start with my neck, and then I want to look more specifically at the shoulder blade. So then I'm going to ask you to go ahead and shrug your shoulders up towards your ears and hold them there. So this is why the markers are really, really going to be key. And then relax. And now round your shoulders forward. Good. And so again, most of what I'm looking at is a comparison between the two. Bring them back. So I'm looking to see if that's a similar type of movement. And in a lot of patients that have shoulder dysfunction, it's not. We start to really see problems with this. And then what about that one down and in, Rich? Yeah, he's really giving you a skewed view because he's very good. So he can do all these things with good control. So normally that would give us a tremendous amount of information. So that's an important one. So that we call shoulder blade movement or scapular movement, okay? So we've looked at the spine, we've looked at here, and now I'm going to go on to the shoulder. And so you'll notice that I keep my eyes mostly on the back, so that's something to kind of think about. So we'll go through the normal motions now, Richard. So thumbs are going to lead, and I'll kind of walk you through them. We'll start with the one going up forward as far as you can towards the ceiling, and stop at the top. And so again, for me, I'm looking at the amount of movement. So this was where that goniometer we talked about last time, where you could come in and you could do a movement, or a measure of that movement very easily, I think. Visually, I'm also looking, you can see that the shoulder blade goes through a normal rotation with that, and again, because so many of our problems in the shoulder come from a problem in that rotation, I'm watching that as well. So I stay always from the back, okay? And then come on back down. Good. Let's go into scaption. So that 45 degrees. Good. And then come on back down. And it is that pace, so we don't need speed on this, so that's helpful. Right? Okay, and then out to the side, yeah. Right up. That's better. And then come on down. Good. So I think that's doable, right? I think with the markers we'd get a lot of information from that, yeah. And so, Richard, bend your elbows. Keep your elbows in, and let's try the rotation out. So, and again, if, you know, a person might want to walk around and see that from the front if they need to, but you could get a lot of information staying right here, and then back to the middle. And then let's take elbows up to 90. From here, same thing coming, oh, you can go down first, sure. Okay. So again, if that's not really easily detectable, you could come here, right? So in that lab simulation, that I was thinking about these things, and I think that's very doable. And then staying in that same arm up, and now going up with the hands. Okay, so we're coming into rotation in this position. Good. And then come on down. Yeah. How about reaching up behind your back? So we can also, I mentioned this on that sheet, Christina, that there's some functional movements that we might do. We maybe don't do them with every single patient, but we could do something like this. And then we'd compare. So the other one, Rich. Okay, and then coming overhead with this as though you're reaching down there. So I don't see any challenge with that. Do you guys?
No, I don't
yeah.
really.
So far, I think this is all doable.
The only thing I wonder about is, so you haven't written a single thing down yet.
Oh no.
Right.
That's
so
just because it's in my brain.
You're processing this.
Yeah.
Yeah. And so at the end of the day, then presumably what you're doing is you're looking for a red flag. Is that
I'm
right?
looking for, well, a red flag or anything that's different. Anything that's different. And then based on that initial chat with our history and getting the story, the patient comes with things that fit the puzzle. So really that's what we're doing, is we're kind of building a puzzle that fits together so that at the end of it I can look at that made puzzle and say, this is what's going on. And then again for us, this is what we're going to do to fix it, right? Because that's the difference between really a physician and what we would do. Is a physician would really be I always think they're like the quarterback. They kind of figure out what's going on, and then they have the play, and they say, well, you should go to physio, you need to see a surgeon. But if they come to us, we have to do that assessment, but then we actually at the end of it have to be able to do something with it.
Mhm.
So our evaluation's a little bit different.
Mhm.
If you watch Dr. Sheps do that, he would do maybe 20% of what we would do.
Mhm.
Yeah,
Right.
he's right down to business with a couple things, because his determination is whether or not I can do surgery.
Right,
Right?
right, right.
If I can't, then that's back to Judy.
Yeah, right.
Okay?
Yeah.
Yeah.
I just had
yeah.
a question about the
Yeah.
last one. So obviously we're trying to measure how high it can get up.
Yeah.
But it would also depend on what's happening to the shoulder
Yeah,
blade, right? So
yeah.
I feel like for the virtual system that'd be hard, because if you see my right hand, like I can't get up that high,
Mhm.
Right.
but my scapula stays down. But when I go with my left one,
Yeah.
I can get,
Get
way
it
up,
winging.
but then
Yeah.
I'm winging.
Right.
Right.
Yeah,
Uh-huh.
that's a good point, Richard. So
Yeah.
the subtleties around this is what's going to really be tricky,
Yeah.
because it's not just about the easy measure on how far, like Rich has said.
Yeah.
It's the subtleties around that. So do you think there's anything else we could do other than mark the shoulder blade to really pick that up, though?
Could you show us you doing that again?
Yeah,
That difference,
yeah.
because that's.
So watch here. So there, you know, we'd look at that and say, well, that's pretty good. That's
Yeah.
functional. So watch what his blade does.
Yeah.
Okay, and then show the other one.
Yeah. Pops.
Yeah, and so we call this shoulder blade winging,
Mm.
and that may or may not be important depending on your patient,
Yeah. Right. Right.
right?
Yeah.
Do you think we could get that? Because you can get rotation, like this is the thing with the shoulder blade, is you know, you get this, you can get a very nice picture two-dimensionally, but do you think you guys will be able to capture some of that three-dimension? You
I
should
think
be
you
able
should.
to.
I think what you would want is a reference marker on the spine.
Oh,
Yeah.
of course, yeah,
So if you
that's
had,
a
if you
good
had a
point.
mid
Yeah.
scapular spine marker
Yep,
here.
like here, and
Yeah.
then down to
And-
here.
Yeah, right. Now, and then you know, this marker might pick it up, but you
Yeah.
might want to put one, say, somewhere
Yeah,
here.
do that again, and let's see
Yeah.
if we are able to.
Oh, there it is. Yeah, so it's
Yeah.
pretty close to this.
Mhm,
But
yeah.
I don't know, this has moved up.
has
So the
moved
bone
up.
has moved up
Yeah,
relative to the
yeah.
skin mark. I mean,
Yeah.
that's the one thing I've seen about this more than you see in gait
Yes,
analysis.
yeah,
The-
yeah.
The underlying skeletal movement is much
Right.
greater than you see
Absolutely.
when
Yes,
you're walking.
for sure.
So that's something to really think about.
Right, so that might be something when you get, you know, the first 5 or 6 subjects to really see and to compare the observation piece and what we would sort of fill out on a form in terms of what we think we're seeing versus the person that's looking at it through
Yeah.
VR. That
So
would
the
be
guy
good.
who was sitting on the far side just listening to us when we were at Enterprise Square, Sean,